Okay, guys, we're gonna go ahead and get started. It's February 24th, 2022, 22 week. Did you guys catch that? Like, so every day this week, it's like a palindrome.
Oh, because it's
Because if you read it backwards, it's the same date. People are joining in from home. Okay, if you are joining in, make sure you mute, and I'm going to go ahead and share my screen. Today's topics are just generalized education updates that we want to just review with you all and go over some new things that are coming at us. So get rid of that. Okay. It's down there. Okay. So today's topics, we're going to cover quite a bit, but we'll try to just zip through a lot of this to stay on time. First and foremost, the PCTA line. Basically, we're transitioning that role into an assistant. We're going to talk about RT. They're leaving us, but they're still accessible. So that whole process is kind of going to be a big thing for us today to review. The abuse and neglect screening. We've been going around the unit and trying to make sure everybody understands that that's part of our pre-op process. It did go live yesterday. So we just want to touch base with everyone on that. Infusion pump upgrade, that is hospital-wide. Ortho hip decolonization process, another big topic and process that's going to be in place in pre-op. Our Blitz wrap-up, and then a chart audit task force. UBC is we're going to work with them to try to close the loop with our chart auditing. And then the last thing we're going to touch on is prostatectomy, same day surgery. We have an in-service booked on the 10th, and then go live is going to be 3/14. But we just want to get that information out to you guys and have everybody prepared. So I did send out some information about this whole PCTA line removal. Prior to the last couple of weeks, they had been able to remove that from our patients' radial arteries. Unfortunately, there were some sentinel events that happened in the institution that now we have to, nursing has to own that, just due to patient safety and assessment. So we can still work together. Our PCTs are still able to assist with that process. So once you acknowledge and are ready to remove it from the artery, you, the nurses, will cut the suture, take the dressing down, and the PCT then can apply the pressure after it's removed. Again, more of an assistant role. So you're going to grab your PCT and say, hey, we're going to go remove this art line. You cut the suture, assess that the catheter is intact, because that was the big issue, that when 3 art lines were removed, they weren't intact. And so those patients had to go back to the cath lab and have them retrieved. And unfortunately, you know, it caused, you know, a process. Maybe it was.
But it could have been like a cutting error.
I don't know if it was.
If they didn't use a suture removal kit and they cut the.
It also could have happened an insertion, like if the anesthesia or whoever, the physician, like, I don't know what they would have done like prior to, or like during the insertion process. But so obviously as nurses, we have to assess that it's intact. You're going to check for hematoma, you know, and then the patient care techs can apply that pressure dressing. So apply that pressure dressing in occlusive format, and then inform that the RN that is completed. We still do all the documentation though as nurses, that patient tolerated well, no hematoma, however descriptive characteristics you want to throw in there. But again, more of an assistant than independent task. Any questions about that? Yes, so that's where this slide comes in, and I did send this out, and I have a couple copies. So look at the scope of practice that they can do.
Flushing the inline is more invasive than flushing the line injection.
I hear you. I get it. The rationale behind that, if they flush it, it has to be a direction under like you as a nurse that they can just, you know, go ahead and pull that pigtail and flush it. They're not going to do that independently. They're not just going to go up to your patient, start manipulating the line, troubleshoot anything. That's not an independent task that they can do. It's all a delegated task, and the system is closed. So I understand your thought process, though, that it's an invasive line. It is, but it's a closed system, and it still has to come under the direction of the nurses. So take time to review this in scope of practice, you know, all the urinary catheter items, the things that have the asterisk on it, they have to be checked off with competency with. So removing, or first they have a competency for the bladder scanner, removing the catheter, and then intermittent straight cathing. They have to go through the training with us, and the competency is signed off. IV catheters, so they can only DC those and apply the dressing and reinforce an existing dressing. They do not insert IVs, or they cannot cap them off. And you guys know they can't draw blood from those lines as well. The A lines, like we mentioned, is just going to be a holding pressure, applying that dressing under the direction of the nurse after the catheter has been removed. They can help with the whole process of zeroing the line to the monitor, flush the closed system, and collect a sample from the safe set. Oxygen therapy, then they can, you know, they can swap out the O2 line, hook it up on the flow meter under the supervision of RN or a doctor. And then other blood samples or urine specimens, they can run the VBGs and ABGs on the GEM system. Then labeled specimens, they cannot print labels. We have to, and you have to verify you have the right patient, the right order and such. And then they can perform all of the point of care testing, the glucometer and urine pregnancy on the unit. So we just want to make sure we have like defined measures and practice guidelines that us nurses know what you can and can't delegate to those PCTs, and they also know their role. And so they're getting the same information that you guys are.
Is all our PCTs is everyone in our unit PCT or NA3, or is?
There's only 2 NA3s, Bertha and Van, and their title was basically grandfathered in to our unit many years ago, because prior to the PCT role, they were all nursing assistants, and they have their own union. But then the hospital was doing away with that position, but those that were still here were allowed to keep their job, their title, their benefit, like all of that. So there's only 2 left in our unit. There's other ones throughout the rest of the hospital, but the caveat to that is what they can and can't do.
Vital signs?
Right.
Okay,
So always double check that when you're in.
because in there it said that they can document vital signs.
So the PCTs can, and I can clarify that.
We have a different one that has,
The vital signs.
yeah.
That actually has vital signs. I don't even see
Yeah.
vitals on here, but I guess record output. So the only 2 that can't are Van and Bertha. They just don't have the same MyChart access and then
Gotcha.
credentialing.
They can't
Yes.
chart
It's the
their
same with
Craig.
pregnancy tests too, yeah,
They can't
so
chart Craig, they can't chart Craig.
they can write it on that sheet and say that it's negative, but you always want to make sure that you're checking that it's in the computer.
Correct.
So are they able to bladder scan now, like this and the scan?
Yeah, they can still do that. The only thing that they really can't do is the charting. Yeah, that's basically the
Yeah.
only thing that they're not able to do.
How about them testing, that they can not for them, all the other areas.
To have them chart it. I don't think they have the access to the IV tab in their flow sheet.
And that was one thing that we were supposed to be responsible for, just to make sure that it's out before the patient goes home.
It's one of those tasks that it's a delegated task, but we still, as a registered nurse, have to document it was completed. Yeah, that's all there is to say about that, I guess. Any other questions? So, hot topic for us. Right now, we're gonna go through this transitionary time that our respiratory therapist was designated to like either sit or be accessible in PACU from 7A to 7P because of staffing issues, and they just don't have the manpower to do it. They're no longer able to physically be here in our unit. They, I think recently said they had hired like 6 new people and 4 of them had already gone to elsewhere. They're down like, I don't know, 70 FTEs for the whole hospital. So if you know any respiratory therapists, 70 FTEs for RT. And they're a huge, huge component of our hospital, our care, the ICUs, like they do so much. So their directors, their department, they've, tried to come up with the best way to basically maximize, optimize their staffing. And we still have them accessible. We can always page them and call them and they will come down. The biggest change for us is going to be the process for checking in the patient's CPAP or BiPAP machines. And what do we do with it? So we still are going to label it, communicate with, the patient that it's going to stay with them now. It's actually going to stay on the stretcher, on the bed, go through the operating room, and then it'll be on the bed or stretcher when they come out of the operating room. That same process is done over at Vot. If you guys recall it, we just tuck them either at the foot of the bed or underneath. I know anesthesia kind of bucks about that, like putting it on the, like below the head of the bed in case they got to drop.
We go a couple of those years ago.
I know.
So what is
Yeah.
the best option?
I want to say put it in the bed with them, but then like they're gonna have to take that off when they pull the patient over. So, I mean,
We can trial this too. If for whatever reason we're breaking their equipment, like that's gonna be a no-go. But keeping it with the patient was the quickest solution. RT suggested as well, just keep it with the patient. That way it travels with them through our department. So that way it's not like lost with the wheelchairs. It's not just sitting on a table that nobody's paying attention to. And then that they don't go home without it or go to the floor without it, because our
Yeah.
would always,
Don't want to break them.
yeah,
you could always ask the OR nurse or anesthesia, where do you want this? It's going with the patient. What's the
What
best
I'm
place?
thinking is like put the more softer items, like their jacket and that underneath the stretcher,
Yeah.
leaving room at the back of the stretcher, because it should never get crushed at the back, you know what I mean? That little section
Yeah.
at the back of the
Yeah.
stretcher. Keep the CPAP there,
yeah,
and then,
Well, underneath, all the way what they want to.
that's when we
We
drop the
have
stretcher.
so many times patients stuck.
yeah,
and
Yeah.
it's horrible.
Right.
Yeah.
And they shouldn't go there, period, because
Yeah.
we have too many incidents of that. So we do need to change the practice, but people just bring their own clothes and their stuff.
Yeah.
And start everything. If there is a CPAP machine, we'll go for nothing else.
yeah. The other big thing about this process, the orders and documentation, we're going to review a few more slides about this. So the patient must have an order in my chart from the ordering provider before we initiate the PAP therapy. So if a patient needs it in in PACU, there has to be an order for it. And then for them to use it up on the floor. That comes from the provider, the surgeon, because think of those head and neck surgeries or whatever, that they don't want any positive pressure on that dressing or like in that area. So we have to make sure that we are diligent about making sure we get the order from the surgeon, run it by them and hand over like, hey, they have a CPAP. Is this okay? Or if they say no, nothing goes on the face. And an order has to be placed, so we're not just gonna pop it on. So you do wanna be mindful of that. Respiratory was really good about like checking
Paging,
and
yeah.
paging if it was appropriate or not. So just something that you wanna think about before you go and put the machine on the patient.
So are we gonna do our own breathing treatments now?
No,
Like respiratory is still doing all the things that they did before, minus this like checking in the CPAP and the initially we can place it. They still need to come and assess it and they're still gonna be here. It's just, you're gonna have to page them.
And it's not gonna be accessible at the desk. We won't be able to walk over there. We have to
Right.
page them directly to the.
they only will be available page or calling them.
No, or I think.
There's just a couple slides we added in here, like the difference between CPAP and BiPAP and auto titrating. Just for your review and knowledge, CPAP, you're gonna apply a constant level of positive pressure to the airway, which doesn't augment the alveolar ventilation. BiPAP, that is method of applying 2 levels of airway pressure to overcome airway closure on inspiration and expiration. And then auto titrating, delivery of PAP, that even Jessica was like, nobody uses those. It's just, that's gonna be a patient that probably needs a ventilator at that point, that we're not gonna assess that. So, it's used to support patients with severe sleep apnea, those with chronic hypoventilation. It's essential, for titrating BiPAP. So they have targeted and desired volume that they can pull. There's so many different home CPAP, BiPAP devices. These are just a few that she shared with us. The biggest thing that we talked about with Jessica was like the cleanliness of these machines is somewhat scary when they come in and they're wrapped up in a Target bag or they're wrapped up in a whatever, or they just physically bring it in without a bag. Like there's like, here you go, and it's got the tubing, might still have water in it or whatever. So when, obviously when we're gonna label it or whatnot, we wanna put it in a patient belonging bag and, still wrap that ID badge and stickers and stuff on it. But also we're gonna look at it, and if it's filthy, we're not gonna use it.
I can do like proof exam like this.
Well,
Page respiratory.
regardless,
No.
yeah, we're gonna do a little education to the patient and be like, it's good practice to, keep it clean. You don't want to put a bunch of bacteria on your face in that mask. So if there's any indication, whatever, obviously we're still paging and calling respiratory to like put these on. They're gonna see it too. But they
Respiratory will essentially be the ones
making that call.
making that call, right? They're gonna be
Yeah.
the ones opening up the passport and going, okay, it's okay. No,
Yeah.
no, no good.
Yeah. But don't be, I guess my point of like all of this, these different varieties, like don't be intimidated by the machines themselves. The machines are pretty straightforward. The patients use them at home, so they have to be simple. It's an on-off button. The settings are pre-programmed.
We're not doing any settings.
We're not feeding
just
in
a-
oxygen. You don't even have, Jessica even mentioned, you don't have to add water. Like you can just put them on to a dry seal for the short amount of time that they're gonna be here. And then once they get to their room, the RTs up there will set them up with humidification and they'll have it, on for several hours, like at nighttime. So keep it simple, and we still can page respiratory. Like those are the 2 things that I really wanna emphasize.
Real quick, going back to the, like the positive pressure, patients that should not get positive pressure, right?
Yeah.
To me, I feel like that should fall back on the surgeon who's performing the procedure. He should have that specific order in there. He knows that his patient can't have positive pressure after
Correct.
the procedure. He should have an order in there. Obviously, we're gonna, whatever, keep an eye out for it, but I don't think at any one point that should ever fall back on nurses.
No,
Anyone
there
who's
is an
respiratory
order.
Therapy, or because they're looking for the order too.
Yeah,
And we could just be like, I guess, that advocate to be like, well, patient should receive positive pressure. There is an order for it. So.
But there is that order and it should be in, and most of the time I think it is in with
like
these
no
cases.
positive
Yeah.
pressure applied.
Especially like Dr. Hess has some patients that like
And they
the
do like,
pituitary.
and also they
Yeah.
say
Should everything
whether
fall
like,
back on us?
whether the head of the
That's
bathroom
their
plus-
fault.
No,
Yeah,
no
yeah.
positive pressure signs
Yeah.
sometimes, yeah.
But what you don't want to do is just put the CPAP on because it's there and you don't have an order. So you have to have the order. So
Got it.
even like, maybe they don't have an order that says no positive pressure. You still have to page the surgeon and say, can they have their CPAP placed in order? So you want to have that order before you put the CPAP on. Does that make sense?
Yep.
Okay.
Couple other things about inspection in general. So the inspection shall include the visual inspection of the device, all cables and masks. Ensure the device has not been transported or filled with water. Again, some people don't empty theirs. I've seen them come in and they're like kind of dripping, or like the bag has water in it. I don't know, whatever. Inspection also includes inspecting the case, knobs, gauges, switches, looking for any damage, missing knobs. Switches may prevent the user from making adequate adjustments. While the patient is on their own PAP machine, the PACU humidity will not be used. So kind of giving it an overall glance and look over is the key, and looking for any damaged things and the cleanliness or the.
So we're gonna own
takeaways.
that now. So when the patient comes in with their CPAP, you're just opening it up, doing a brief look at it for the cords, making sure buttons are there and it's clean, zip it back up, and then you've done your check and it goes with the patient. So
Okay.
respiratory is no longer doing this check.
And making sure that the main three items are there, the machine, the plug, or the.
Yeah.
They
and
might
then
come
the
without the
mask.
plug.
Because some
Yeah.
people, oh, I forgot to charge.
Yeah.
it.
You need some.
Jim, what did you touch base with Jim Malloy and let him know that? Because I just saw one of the front desk family waiting clerks bring a CPAP back.
Oh, this doesn't go live until March 10th.
Okay, but what it
Yeah.
does, we just
Yeah.
make sure to
Yeah.
touch base with them,
Yeah.
because a lot of times they'll do it. to get
They
the
bring
hell
them
out of
back?
somebody's
Yeah.
hand.
Okay,
Yeah.
yeah. The question was making sure that unit clerks knew that this go live isn't until March 10th. So that way they're not bringing devices back. Respiratory does have these stickers.
Quick question, if
Oh, yeah.
something is missing, like the cord or the mask, if something is missing, do we still take that, or do we just send it back to town?
So you would take it back with family. Send it if you
Page
can.
respiratory.
Page respiratory. Just let them know this patient did bring in their own device, but it doesn't have all of the parts. The other way that they basically indicate that the machine has been checked is with this sticker. It just says like device sticker checked, and you can pop that on the machine. That way, when the machine gets to PACU to the OR and then the PACU, you as a PACU nurse can look and see, oh, the sticker's there. It's okay to use. The exterior of the device should be reasonably clean. It is recommended that the exterior of the device and power are wiped down though. So if you have time before you throw it on the patient, give it a good wipe down. I know this seems like a lot of extra like steps and work, but when you think about it, we don't apply a lot of these to patients in PACU. You know, they ride on their nasal cannulas or a mask for a little bit, and you have some time, you know, to make that judgment if they're gonna need it or not. There are a couple different types then of the machines or the interface, the mask. So some patients just have a nasal mask. I think the next slide has pictures. A nasal mask just covers the nose only and is held in place with the head strap. The other one is oral nasal mask, covers the nose and mouth, and it again has the head strap or the nasal pillow. So that's only like 2 prongs that go into their nostrils. They all should fit pretty snug though. Just keep in mind that you do want a tight seal so they don't have a leak. And then if a leak occurs, you can just adjust the mask, you know, to your best ability until that maybe whistle or noise that you hear resolves. We're not going to fix them all though, you know, and there are some of these, we call it like a whisper valve that you'll see on the outside of the mask or even on the tubing. Whisper valve functions as an exhalation port to remove that CO2 from the circuit. Shouldn't be occluded, but that can also cause like a noise. So if it isn't occluded, again, if any of this stuff is coming up or you're just like, you're trying to troubleshoot, have questions, page respiratory, because they will still come down and like assist with any troubleshooting that might come up. I know like my biggest fear was like putting them on and then knowing if it had a good seal or not, or like always like thinking like, oh, am I suffocating that patient? Or just having that fear of like, is it too tight or whatever? But you do want a good seal. You're forcing that positive pressure and they're able to blow off that gas. That's the whole like, you know, the whole point of it. Patient, again, must have an order and buy chart from the ordering provider before initiating the therapy. So just like our other, I mean, you're not going to do it unless you have an order. Bottom line. So how do we contact respiratory and or when? So awake patients should be able to put on their own machine. That's huge. Just keep in mind, like these patients do wear them at home. Although in PACU, like they probably need it because they're too groggy. But you can guide them and say, hey, we're going to put your breathing machine on, the one that you use at home, and they might be able to just like finagle it and position it on their face the way they do every night. So have them try to help you. If the patient's unable to put it on themselves and nursing needs assistance, we're going to page respiratory. If the patient requires oxygen, we have to bleed in oxygen. We want to call respiratory. We don't want to set up that additional O2 to bleed in. We want them involved just in case, you know, anything else does kind of escalate with a patient. Pager and phone number remain the same. They're going to be on the walls over there and like our phone list, whatever. If you're unable to reach a respiratory therapist that's assigned to us, we can call their supervisor and we'll have their number available as well.
So anytime you hook up the CPAP, you get the order, you hook it up, you still have to page respiratory because they still have to come down and do an assessment on that patient. So anytime you hook it up, you still have to page them so they come down and do an assessment because they chart on all the CPAPs. So they're still going to be here helping us. You can just initiate it.
Any
That's
questions?
like you want to do that thing.
Any other questions about
I'll
respiratory?
let you know what.
Act like you know, fake it till you make
Make it
it.
till you make it. No,
Anesthesia will also, like they still can, they'll give our breathing treatments and pre-op. They can pull all the respiratory meds and give treatments in PACU as well. So just know anesthesia is our other respiratory therapists. They have them as, you know,
Yeah, they're backup. We're good.
backup guidelines. I'm not going to take a ton of time on this abuse and neglect screening, but it did populate in our MyChart tabs yesterday.
Remember to
So
move it up your screen. I just moved it up for someone so that you can remember to do it.
it is a JCO requirement, and to increase patient safety, obviously, Michigan law mandates that any healthcare provider must report suspected abuse or neglect, including nurses and physicians. Not going to read over that huge slide, but this is where it's going to appear in your arrival section in pre-op. So the 3 main questions that you're going to ask: do you feel like you're do you feel you are not treated well by your partner, spouse, family member? Have you been hit, slapped, kicked, pushed, shoved, otherwise physically hurt by one of those members? And has anyone ever forced you to have any sexual activities? You know, a simple yes, no is pretty straightforward, but there's going to be other caveats. So maybe they're not able to answer because of a medical condition, their age, due to privacy is kind of a big deal in our department. You can, if you're getting a patient up to the bathroom quickly in pre-op, you could say, hey, I have to ask you these questions. We ask every patient in the hospital, have you ever been, you know, physically, sexually abused? Do you feel safe at home? Like you can subtly do that if their spouse or somebody's at the bedside. I remember in the ER, that was always like the most challenging question to ask people. And sometimes you get like this look from patients that just gives you the like, I can't answer that, you know, because somebody's right beside them. So read their body language, kind of get a vibe. Hopefully majority of our patients are safe and, you know, but you never know. We can come across one or two people that we do need to be an advocate for them. So then you indicate physical abuse, sexual abuse, neglect, yes or no. So if they do indicate yes, and we answer that it's a positive screen, what now? So what do we do? We get social work involved right away. For UH and MPU, we have a pager number. I'm gonna post this at the clerk's desk. I don't know if I did that yesterday. The attending surgeon needs to know, anesthesia, and then social work and the whole team will have to consult and make a decision on how we're gonna proceed. You know, not the most comfortable situation to be in, especially when they're like waiting to have a surgery, and then now you're throwing this on them. I don't necessarily foresee that a lot of surgeries are gonna get canceled for this reason, but they will have to have follow-up. And that's the biggest thing, that they at least have a resource then to follow up. Any questions on that? Sure, if you want to do it.
I can handle this. Okay, so infusion pump software is being updated. It's already started. This is started in Mott. You probably saw this already. The main thing about this is the pump, the module, and the brain all have to have the same matching colors. So you can't have like a green sticker mixed with an orange sticker. And then if you only have orange stickers on the modules, then you can't connect that with a green sticker on the brain. So just make sure when this starts here in the main that the colors are aligning. Any questions about this? This has happened before. This is our second time having this upgrade.
What's the significance of
Because it just means the orange has been updated. Yep, so you can't combine updated and non-updated. So if it has orange, it's been updated and you're good to go. You can still use the green, but then you have to have all green. Questions about that?
I was just
Do you have a
looking at our
sample?
supply rooms. We have pink. They don't say anything about pink.
That's
I think it's
the,
just the
old.
like old one, but
Yeah.
if you see pink, that just means
Like you can
it's not
use it.
upgraded. It has to have the orange sticker.
And when is that starting?
It
already
started in February in Mott, but they're gonna do all of Mott and then come to the main. I don't know if all of Mott, have you noticed this at Mott yet? Okay, so maybe it's taking a long time. It'll probably be middle of March before it gets here. I'm not sure. They were gonna finish Mott and then come over here. The other thing that we're starting is the ortho hip decolonization. We have done this before. It kind of slid to we didn't really have a good policy about it. So it's back and it should be staying back. The people who are doing this are urgent, emergent ortho hip patients, the ones coming through the ED. They haven't had a chance. It was an emergency. They fell at home. They didn't bathe. well, we need to bathe them. It's gonna help prevent infection on these patients. The other thing is we're gonna do the antiseptic swab with them in the nose. And they'll be in order, and it will be in the pre-op phase of care. So you're only doing this with an order on those emergent hip patients.
I did have a list, like, so it's gonna be like a femoral neck fracture, trochan, I can't read my own writing, trochanteric fracture and subtrochanteric fracture. So those people that hit the ice and fell and were sitting in the ER all night, and now they need surgery. So it's not gonna be your planned patients.
We have a little sample. So it's a kit that you
These are the-
get.
Kids, yeah, go ahead, sorry.
And I don't think we have them quite yet. We kind of stole a sample, but as soon as we get them, then this will go live.
I
We don't
think,
have them.
okay, I was gonna ask you if,
That's a special order.
So it could be a bit. Okay.
So is there a different one from the one that's been in the warmer?
Yeah, so the warmer is just the wipes.
There are more items.
and this comes in a full, like a package, so it has two things in this package. So you have the wipes, that you're gonna bathe them, and then we're gonna do the skin, the nasal decolonization.
Since we store all those wipes, why did we just order this one?
Margaret had a reason for that. We couldn't get them stuff. I don't know. She had a reason why, like they needed the whole kit. So, this is just telling a little bit of difference between the swab, I want to call it provolone, but it's provolone. It's reminding me of cheese.
Jeez.
Cheese is different than Bactroban. It's just, the provolone is an antiseptic. And that is what is used if the patient, so for elective hips, they're all doing the Bactroban at home. So they get this ahead of time for surgery. So this select patient hasn't had that decolonization yet.
It's done like I think don't they do that 3 days before?
Yeah, so they have orders at home. They have the stuff at home. They're already wiping themselves up. So this is for the patient that didn't have this chance. Yeah. Yeah, so the directions are here. So there's like 6 steps to the swab. Okay, so you use a tissue to clean the inside of both nostrils, maybe have them blow their nose ahead of time. We're gonna have someone come by here and check us off on this.
He's gonna do like a
Little,
product rep is gonna come do like a actual in-service for us, so.
and these directions are on the order too, like it will tell you, and I think it might
On the
be
package.
on the package. Yeah, it tells you exactly how to do it. So you tilt the bottle slightly, you dip 1 swab into the solution, stir vigorously for 10 seconds, withdraw the swab slowly. Avoid wiping off the solution. You don't want to like unsaturate what you just saturated. You insert the swab comfortably into the nostril, so comfortable. And then you rotate.
Swabs too.
Yeah.
If you look at those, they're actually pretty big.
But you're not going back like a nasopharyngeal swab. We're not going that far in. They probably could, yeah. Yeah. So you could just kind of walk them through the process. You do want to make sure that they rotate it for 15 seconds, covering all surfaces, and then focus on the inside tip of the nostril and rotate for an additional 15 seconds. And then you use a new swab and repeat the steps for the second nostril. But what you do it a total of 2 times, right?
Yeah.
Each nostril gets it twice. And then the CHG wipes, there's directions. These directions are already in pre-op. There's a little piece of paper. Essentially, you're cleaning their chest with 1, their arms with another, their abdominal with another, and then their legs gets
So
1.
These
And then they're
packets
back.
come with the 6 wipes, whereas the other ones that we already have are 3. So that could be another reason why, because they essentially, I know.
You gotta use all
I'm
six.
just pointing out the differences, but I don't have costs. I'm sorry, that's bottom line, but but you are to use all six.
And you
Like a
wipe
lot.
it for 20 seconds.
But I think it's something else that you can just hand the patient.
Yeah,
You know, but if it's the sweet little lady that broke her hip, whatever, like she might not be able to get everything, but have her do her underarms and stuff and you do her bottom. Were you gonna say something, CJ?
Yeah, it's the rationale for swabbing.
So just to get rid of, like, the whole infection prevention is the key behind this. So yes, we're doing hip surgery. What does your nose have anything to do with it? That's,
yeah,
Yeah.
and it's an antiseptic, so it's just cleaning.
yeah, it's just festering in there.
So don't be eating them. It'll be in your whole body.
Swab
Okay.
first, then eat.
This way they can pick their nose later. Okay. So anyways, you'll have an order. We're gonna have a rep come. But yeah, essentially the patient can do this themselves. It's okay, but you might need to help them with that area in their backside. We're done.
Any other questions
Hurry.
on the,
We'll get you,
on
Sheila.
the ortho patients, the decolonization? Okay, yes, so Blix, yep. I think there's a slide.
I
of the
think I had
order.
a slide,
That,
or was it, did I just pass it?
yeah.
Oh, this is what the order looks like.
So it says,
Yeah,
it just says like apply to these nostrils, clear swab for 30 seconds. repeat. We're on city lights. So one
I'm sorry,
is
what?
for, the swabbing, and the other one is for the cloth.
abuse and neglect is already live. It started yesterday. This is going live when we have the supplies.
Has
What do you
memory
mean?
issue with it, we'll have to help them.
Abuse and neglect. There's an option on there that you cannot screen due to medical condition or unable to talk, then you would look for the indicators. So if someone can't answer, then you look at those indicators and look for signs. Either it's yes or no.
By the way, one of those packages is $19.
Oh, wow.
How about the others?
Does anyone want to swab their nose? Just kidding.
I didn't open it, I swear.
Yeah, the package isn't open. Okay, so I did send out an email to everybody that didn't turn in their BLS cards. So you need to turn your BLS cards into Amanda Palmer. So she's the one that collects cards.
Share with your friends, tell them they go
Yeah.
to Amanda, because it goes on in your blue folder for JCO. That's where they are visiting and they want to see Catherine Ferguson's blue folder, see all of her education, her certifications, everything. They're gonna pull your folder and Amanda will have a copy of your BLS that it's current and up to date. So that's why it goes to Amanda. Everything else, it is electronic. Like if you've taken it here, it filters into your M-Learning as well, but they still like to keep a hard copy in your blue folder.
Yeah. You guys have access to the.
Yeah, we both do.
You don't have a tax, there's no tax on it now.
Oh,
Go Red.
okay.
Thank you.
Sorry to interrupt. No.
Anyway, so thank you everyone that was floating and got to your classes. It was good. I'm glad that we're done. Almost. Oh, what? I mean, we still have more, but like, okay. Chart audits. Everyone has probably had a chart audit at this point. They're being done. But there's nothing really going on beyond the chart audit. So Noreen has a nursing student right now and she has this project going on. So she is looking up articles and research about peer-to-peer chart audits. Like what are we going to do with these chart audits? We need to do something with them. So we feel like there needs to be some follow-up with you guys, like, hey, we did this chart audit. This is what you were missing. Do you have any questions? Things like that. So we're going to start a chart audit committee. This is coming from UBC. So we need some people that want to be responsible for like performing chart audits and then following up with staff. So you would be like a peer-to-peer interaction. Instead of you guys getting this email from this outside person, it's actually going to be you going up to people and saying, these are your chart audits. This is what you missed. This is what you need to work on. So go ahead, Sheila.
We did this before. We did like a few of us did like the audit. I
Mhm.
don't remember how we did it, but like for a certain, yeah, we were assigned like certain spaces or certain slots to audit.
Yeah. I'm not sure. We haven't been doing like
We haven't
chart
done it in a
audits,
while.
just like they just started. So we feel like there needs to be like, we need to close the loop and just like complete the education portion of it. So if anyone is interested in joining this committee and starting, you know. Anyways, email your UBC chair and co-chair. Well, everyone knows what you need to be charting. It is on that standard of care. Everybody gets it in orientation. We went through it during Blitz. We talked about it. We've had a whole in-service on it. So you know what's expected when JCO comes around and they say, show me your charting. We have a policy on it, so you know what you should be charting. Sometimes it gets missed, and part of your annual review has some things about charting. So we need to hold each other accountable, and we just want like staff to educate and go up and be involved. This is a great opportunity to advance your framework, or if you are a level E, to keep your and maintain your level, your framework. That's all. It's not meant to be bad, or it's just meant to close the loop. The other thing that is going to be happening, prostatectomies are going to be going home. Some of them, a very, very select few. This goes live March 14th. We are going to do an in-service on March 10th. So we'll have someone come down, talk to you about it. It just really means they're going to be staying longer in PACU, like maybe 4 hours. We're not necessarily doing anything different. They already have like the select population that's going to go home. They're going to go home and have care at home. I don't know if you guys have been reading your emails, but university is really promoting this care at home. So they'll still have like nurses that come in and check on them. It's just going to be a longer PACU stay because we're going to be getting them water, and they're still going to go home with a Foley. So it will be like Foley teaching and things like that. So that is coming up. That's it. That's enough changes, right? Any questions? Radhika, what did you want to say? Yeah, we still have. You want me to mute it? Let me see if there's any questions in the chat. I don't know how to get this. Any questions? Okay. That's a wrap up, then we'll stop the video.
So I was on the live yesterday driving back home, and I see this guy on the phone, and it was interesting how he's on the phone and driving, and then the car goes over. And then I see him taking out his house, he goes like this, and then he looks at, and he shows it. And I've never seen a grown up man doing that. I couldn't, but it was my first time in my life. I saw. You have to start if I be anyone the longer you get. That's why I didn't want to.
In the car,
Yeah.
And then it's gonna touch all the door
But
handles.
it was like 2
They need-
minutes.